Good afternoon, everybody. So we have doctor, no doctor, no doctor. We're just going to eliminate the doctors and go with first names, if that's okay. Let me start by asking, Leana, let me start by asking you, when you think about gun violence, we've got people here from 3 big urban centers. When you think about gun violence, what does it look like in a day in the life of Baltimore?
I think we have to first start acknowledging, as was just said by President Lowe, that there is no question that gun violence is a public health issue. I don't know who thinks that there is a question about it in this audience, but just to say why I think that's the case, I'm an emergency physician, and in the ER, I've treated patients who have died from gun violence, so it's a health issue. But we also know, based on science and research, that violence is something that spreads from person to person. It spreads like a contagious disease. We can map out where gun violence is happening, and we also know that just like a contagious disease, there is a way to prevent it, there is a way to treat it, there are interventions that we can do about it, but we have to first start acknowledging that it is a disease, and therefore, we can interrupt violence as it's occurring, and we can acknowledge, and I'll end with this, that we can acknowledge that we can't separate violence from trauma. Mm-hmm. You know, one of my outreach workers, who we just had an event this morning, and he reminded me that it's hurt people who hurt people. And if we only look at people in Baltimore as the perpetrators of violence, we are really missing how we got to where we are. And we're missing the big picture, too, of the racial inequities and the structural racism that got us to where we are, too.
Well, a lot to chew on. We'll come back to. But Babak, talk a little bit about what it looks like from your vantage point in the emergency room.
Well, so the trauma centers in the United States stand on the ready to receive anybody who's injured, regardless of the nature of the injury. But an element that's very unique to the United States is the preponderance of gun-related violence in particular, to the point where prior to coming to George Washington, I had the privilege of working in Philadelphia at the University of Pennsylvania. And there, we had a number of European surgeons who would come through on a regular basis for weeks to maybe a month at a time, simply to observe gun resuscitation from gun-related injuries. And you know, that is, in my opinion, that's a mark of shame, that the Europeans have to come to our country to learn how to resuscitate a gunshot victim because they don't have enough of that in their own country, is not something that we should extol as a marker of excellent health care. I agree with Leana. This is a public health crisis. It is a scourge. So we stand at the ready to receive anybody who may be wounded, and with the knowledge that at any moment in time that can happen. That's what a day looks like.
How often do you see somebody with gunshot wounds?
So luckily, and the statistics here will be a bit sobering, George Washington, thankfully, is not considered a very high volume penetrating trauma center. So here's what a low volume penetrating trauma center looks like. We see roughly 2,000 traumas per year at GW, of which about 15%, are penetrating. So that means 300 or so gunshots a year. That's 1 a day, and we're considered low volume. That is striking. A high volume trauma center may see upwards of 4,000 or 5,000 trauma patients per year, and we'll see about 25 to 30% penetrating trauma. And so that's the story.
Wow. Scott, by the way, since he's University of Pennsylvania, you're at Temple, that's why we have somebody in between you.
Yeah,
That's why we kept you
I'm
separated.
actually a huge fan.
Yeah. Talk a little bit about what it looks like from your perspective.
So, you know, to his point, you know, at Temple, we treat more gun victims than any other hospital in Pennsylvania. And that's because of our, you know, we're situated in North Philadelphia. We have probably 3 or 4 of the city's busiest police districts in terms of firearm injury. You know, in Philadelphia a couple years ago, we only went 21 days without a shooting in the entire city. On most days, 3 to 5 people are shot. Somebody is shot every 7 hours in the city of Philadelphia.
Just to clarify that, there are only 21 days in the entire year where no one was shot.
Right.
Okay.
So, you know, it's not when I pick up my phone in the morning and I see which pages came across overnight while I was asleep. It's not a question of whether or not there's going to be a gunshot victim on that paging system. It's a question of how many. And so it's a constant drumbeat of gun violence. And this is to Leana's point. This is a traumatizing feature of living in neighborhoods where they're disenfranchised. There's a racial component, obviously. And so violence isn't really the cause of the problem, it's really a consequence of the broader problem.
Well, Leana, let's go back to where you started, because, saying this is unequivocally a public health problem. Now, maybe symbolically, we have finally seen the prohibition on the CDC examining this lifted. I don't know how much that's going to mean in practical terms. Maybe we'll talk about that in a minute. But if that is, in fact, maybe a turning point where we can begin to look at this more through the lens of public health, what are some of the insights? What are some of the directions that would take us if, in fact, we did view this more as a public health challenge?
If we understand violence and gun violence to be a public health issue, then the solutions that we apply are public health solutions. I'm not saying that there's no role to work with public safety, but rather that we can look at it from a public health perspective. So I'll give you a couple of examples of things that we're doing in Baltimore. One of them is a program called Safe Streets. There's a national cure violence model, and the idea is that we hire individuals who are from the communities that they're serving. Many of these individuals are recently released from incarceration. They're former gang members, former drug dealers, and if I were to walk the streets of West Baltimore and say, please don't shoot, violence is not, you should break the cycle of violence and trauma, I just don't think it would go so well. But if somebody who has walked in the shoes of the people that they're serving, if they are the ones who are saying that, then it carries a lot more weight. And we have 4 Safe Street sites in our city that cover 1.5 square miles. Last year, the outreach workers interrupted 1,000 conflicts as they were occurring. And an independent study found that 80% of those conflicts were likely or very likely to result in gun violence. And as the gun violence in our city has unfortunately escalated in the last couple of years, we have had 3 of our 4 Safe Street sites go over a year without a fatal shooting. And so it's one example of how when we don't see people as problems but as solutions, it's something that, it's a type of public health approach. And I'll add one more, which is that we see all these other things that promote health and well-being as also reducing violence, reducing lead poisoning for our children, keeping our kids in school by treating their asthma, treating their mental health, getting them glasses. I mean, maybe, we found out, for example, in our city that up to 10,000 of our kids were missing something as basic as glasses. Okay, I don't need another study to tell me that if kids can't see, they can't read. But they may also be labeled as being disruptive or be put back in school because what they needed was a simple pair of glasses. So we see these types of interventions also as improving the well-being of our kids and reducing violence.
Can I just follow on one thing? You said something very provocative. You think of violence as a contagion, like other contagious health challenges. How does that inform either your Safe Streets program or others? I mean, where does that insight take you in terms of operational policy?
It allows us to use data and the best practices of science to be able to interrupt violence. And so Safe Street sites, for example, are chosen based on very specific criteria for where we should have them that will make the biggest difference. And they are interrupting right at that point of conflict, just before the gunshot wound is to occur. I think in a similar way to if we were to prevent contagions and outbreaks of other illnesses.
And the idea being that by interrupting that specific act of violence, you are also potentially preventing retaliation.
That's right.
There's a whole cascading effect. Scott, talk us a little bit about some of you have an extensive, this is what you do.
Sure.
Deal with the community. One of them in particular called Fighting Chance, but there are several. Talk a little bit about how you try to deal with the community in a way that interrupts the cycles that we're talking about.
Well, sure. One of the more practical things that we're doing is we have a program called Fighting Chance where we take medical staff into the communities that have the highest rates of firearm injury, and we educate the community members in terms of hemorrhage control and how to stop the bleed and how to respond in the wake of the shooting so that they're not merely standing by and that they don't feel powerless. And this was an initiative that came from the community where they said, is there something that you can teach us because we find ourselves kind of standing around and we watch our loved ones bleeding to death. And in a sense, then, there's a national movement called Stop the Bleed that I'm sure you're pretty much aware of.
Mm-hmm.
But the one difference, and I think Stop the Bleed is amazing, but the one difference in what we're doing is we're specifically targeting those communities using real-time data like Leana was talking about. Philadelphia, their shootings are provided through open data. And so we can use police data in real time to figure out where the shootings are happening. And then we can connect with the community groups in those areas to begin facilitating these trainings.
Explain a little bit about how you kind of find the people to train. Do you work through churches? Do you work through schools? Is it, how do you kind of, do you set up a storefront? I mean, what do you do?
Well, literally, it is making those cold calls and connecting with those. Because of our relationships in North Philadelphia, we kind of have a sense of who's operating in those communities and just reaching out and sometimes just dropping by and saying, listen, this is, we are aware of the shootings that are going on. Because of some of the other work that I do, I know a lot of the people there. And then we arrange to do these trainings, and we'll oftentimes do them in schools, we'll do them in churches. But this is a community-driven initiative with the hope that, if we can save lives. I mean, one of the things that you find is that if people die as a result of these shootings, and sometimes with preventable injuries, there's going to be a sense of a need to retaliate. And when talking about this contagion factor, their friends will oftentimes feel that they need to avenge those shootings. I meet with every gun victim who gets admitted to the hospital as part of my role. And some of the conversations I've had, I'll ask guys, is this what you thought being shot would be like? And they always say, no, I wouldn't wish this upon my own worst enemy. And when I ask them, what do you intend to do with this? A lot of guys who survive being shot, and in Philly, more than 80% of people who get shot will survive, they'll say, I'm just going to write this off to the game. This is not something that they want to happen, but if not for folks intervening with these kinds of programs, I would be remiss if I didn't point out that Miss Erica Ford is in the audience, in the orange there. She is a legend in this game. She should be in my place. I should be out there holding up a phone looking at her. But because of her work and this kind of hands-on approach, targeting these communities, working with folks in the communities, she's been able to drive down the shootings and eliminate it for extended periods of time in areas where you have lots of violence. It's really about going in there and providing these folks the things that they need: therapy, jobs, experiences that take them outside of this kind of day-to-day violence.
Let's come back to the therapy point about and the hurt people point, but you study preventable deaths, and you talked about that issue as well. What are you learning in terms of where the biggest points of leverage are in reducing the number of preventable arrests?
Yeah, so we started our efforts in prevention of injury about 3-4 years ago now, probably, where we tried to look at gun-related injuries specifically after the public mass shootings, all of these active shooters that unfortunately one hears about these days. And so we wanted to know, we wanted to try to inform policymakers as well as medical directors and the good old-fashioned bedside doctor on what happens when a mass shooting event occurs. When you have a Sandy Hook, when you have a Parkland, a San Bernardino, a Pulse nightclub, Mandalay Bay. I mean, they could just go on and on and on. And so what we found is, roughly speaking, and this is a review of actual autopsies that we got from all these events. What we found is that in the neighborhood of 85% of people are dead. There is no opportunity to rescue them. And so that really needs to inform our policymakers that the only opportunity to prevent death on the order of 85% of the victims is to prevent the injury in the first place, which gets right back to Leana's point about this being a public health crisis. You can have all the infection you want. My antibiotics are not going to work. You're going to die. So we have to prevent the infection. The second aspect is, what about those 15% that are currently dead? They were all autopsies. What are the opportunities for rescue of those individuals? And to say that the answer is complicated is an ultimate understatement. It involves better collaboration between police and fire, rapid extrication of the wounded from the area of the shooter, rapid transport of the wounded to trauma centers. Hopefully this event has occurred in an area where there's a trauma center nearby. Trauma centers are not exactly ubiquitous across the country. They're very lopsided to the cities, and even within the cities they're lopsided. And so we've tried our best to inform the facts behind this whole issue in a very emotion-free, fact-based way.
Let me ask all of you this. If we did a pie chart of all of the factors that produce elevated levels of gun violence, segregation, concentrated poverty, lack of opportunity, trauma. How big a piece of the overall problem is the access to guns? How much of a dent in the overall problem could you make by making it harder to access guns?
I don't know the exact answer to this. Maybe my fellow
I don't know if
panelists
there's a
do.
percentage,
No, but I mean,
in your view,
right?
How central is that?
You know, I want to relay something. So I was speaking at another event earlier today about overdose and the opioid crisis, and I think it plays into this conversation too, because it was asked. And we talk a lot about, well, what will work for reducing overdose? And some people will say, oh, well, we need more education. You know, we need to have campaigns for just say no to drugs, kind of for kids, right? Except that studies show that those campaigns don't work unless it's accompanied by a comprehensive youth health and wellness strategy. Because if the future that our children will grow up to have is one that they want to escape from, then they turn to drugs. And just saying no just doesn't work. And I would say the same thing about violence, gun violence too, but violence too, that we need to look at jobs, we need to look at opportunity, and we need to change also the norms that we have. So I don't know the answer to this.
The norms among who? When you say the norms that we have, who are you referring to there? The norms in the community, the norms among policymakers, the way people respond to provocation. What did you mean by that?
I think all of the above.
All of the above.
I think all of the above.
How about you? What do you think? How big a piece of the overall puzzle of the violence you deal with is the relative ease of access to guns?
Well, it's hard to shoot people without guns, so it's kind of a major. No, I don't mean to be trite, but one of the challenges is if guns are easier to get than jobs, and there's a prevailing sense of hopelessness. You know, once a gun, and I do a program called Cradle to Grave, where I talk to kids about the scripts that lead up to shootings and what happens and alternate endings to these scenarios. And I explain that once you bring a gun into that equation, it changes the dynamics of everything. In order to retaliate, if that's something that somebody's going to seek to do, they're not going to punch somebody in the mouth for having been shot by that individual. They're going to retaliate in kind. And if they shoot somebody who will serve as a proxy to that person, now you've got another family involved, and so on and so forth, and it goes back and forth. And as long as the gun is the thing, as long as the gun takes it to that next logical level, it's hard to walk that back, and it's hard to kind of wrap your arms around it. So I think the access to guns is problematic. We have a lot of individuals who are using those guns who are otherwise prohibited, but because of our laws in Pennsylvania in particular, where you're not required to report lost or stolen guns, or at least nobody's being prosecuted for failing to report lost or stolen guns, it allows for a thriving straw purchase market, you know, an illegal gun market. And so I think that that's obviously one of the challenges, keeping guns out of the hands of prohibited individuals.
If I can expand on that. So I agree with Scott and Leana, obviously. Study after study has shown again and again that the more well-written gun control measures exist, the lower the incidence of gun-related violence. Now, gun-related violence comes in two flavors: homicide and suicide. In reality, nationwide, suicide is the far bigger of the two problems, far, far bigger. To some degree, thankfully, we are becoming kinder, gentler. Homicide is actually dropping in that sum, although mass casualty events are on the rise. Suicide is the exact opposite. Suicide is actually very much on the rise. Now, it used to be said, well, if you take away someone's gun and they want to kill themselves, then they're going to hang themselves, they're going to overdose, they're going to jump off the bridge, they're going to do whatever it needs to be done to kill themselves. That is categorically not true and has been proven. That people will not kill themselves if the immediate availability of a weapon is not there. Furthermore, people will not kill themselves. The probability of suicide drops exponentially if there is a cool-off period. I decide I'm going to kill myself today. If I can't get that gun for about 48 to 72 hours, there's a good chance I'm going to change my mind. There's a good chance I'm going to ask for help. And you could save that one individual's life. That's on the suicide arm. Similarly, the homicide side.
Yeah, let me bring in the audience in one moment. I just want to ask one more quick question. I've covered gun control debates for over 25 years, since the big Bill Clinton fights with the NRA in the early 90s over the Brady bill and then the assault weapon ban, which they actually did pass. And it seems to me over the course of this 25-year period, gun control debates are less and less and less about guns. The specifics are less integral to the outcome. It's become, the NRA's goal has been to make it more of a cultural statement of, you either respect my rural values and traditions or you don't, without getting to any of the specific issues about, why do you need a silencer? Why do you need an assault ban, et cetera? I'm just wondering, have you had interactions with public health people in rural communities? And do they see this differently than you do, or do they see this similarly to what you do? If any of you have had those kind of exposures.
A very good friend of mine who is a world-renowned trauma surgeon, I'll even name him out because he's just such a good guy, Dr. Ron Gross, is chief of trauma surgery in Massachusetts. And he's a retired United States Army colonel. And he and I talk about this, and he owns a gun, and I have no problems with him owning a gun. In fact, I have tremendous respect for him owning a gun. But he will tell you that, this is not about getting rid of the guns. This is not about getting rid of the Second Amendment. That is not even part of the debate. It is about responsible ownership, and it's about ownership within limits. Ron cannot go out and buy a bazooka. Ron should not have a silencer.
The question is, does it look different to you from your vantage point than it looks to someone in small town America?
So my only, I don't live in small town America. I live in Philly, and I'm a gun owner. And so the only perspective that I have is from the people who visit my Twitter handle, which from rural America, and they don't tend to agree with me when it comes to responsible gun ownership. But I actually had an exchange not long ago with a group of individuals who were attacking me for my position, and I actually invited whoever wanted to come to North Philly to get some vantage, get some insight into what we see up here. And actually, one guy took me up on it. He's not visited yet, but I encouraged him to come through and see the kinds of things that we do. I think it's important to have these exchanges of ideas and perspective. But I think that for those individuals, they believe that we're trying to punish them for what goes on in urban America, and that's not the case. We're simply trying to find compromise that is going to be mutually beneficial.
Do you want anything, or we can go to the...
I would just say that it's, I can imagine that the conversation would be different in large part because we've suffered so much in urban cities. And I feel like I keep on coming back to the race issue, but we're just after 3 years after the death of Freddie Gray, in police custody. How can we not think about the race issues when thinking about gun violence? And I'm not sure that those same conversations persist in other areas.
In other parts of the country, yep.
Hi.
Oh, no, you got one in the back.
Hi, my name is Abigail Sewell. I'm a medical sociologist by training and a professor of sociology at Emory. And I have a concern. I completely agree with you that gun violence is both a disease as well as we need a public health tool to treat it. However, in order to get to the public health model, you have to go through the medical model. And I know from prior illnesses or things that have become illnesses, the medicalization of social problems sometimes actually is accompanied by further increases in inequality. And what I'm curious about is what types of strategies and tools does the healthcare profession, both public health and medicine and everybody in between, have in place or are willing to engage in to make sure that the inequalities are not exponentiated?
Interesting. Leana, any thoughts?
It's a fantastic question. I am practicing in the ER, and I don't have a great answer to this, but practicing in the ER, I got quite disillusioned when I knew that what I was doing for my patients was only helping them with that Band-Aid right there, right? I could tell my patient with heart disease, you need to eat better, but if I ask even one more question and I find out that 1 in 3 African Americans in Baltimore City, she lives in a food desert, what am I really doing? How am I really doing her a favor by saying you should be eating healthier foods? And so I think that the recognition of the social determinants, really, that has to come into play when we're treating gun violence as well. And so specifically, if I see a patient coming into the ER and they are the victim of a gunshot wound, any gunshot wound is a near homicide, right? Because if the bullet traveled just a little bit more, it would have been a homicide. Is there a way for us to intervene in that moment? And then what can we do further upstream so that we're not just treating the Band-Aid and medicalizing it, but we're really understanding the whole structure and context of that person's illness?
Do you want to add to that?
I agree with that.
Scott. We have one more, yeah.
Hi, my name is Adam Foss. I run an organization called Prosecutor Impact. Thank you for this panel. One of the frustrations that I have as a prosecutor is seeing us trying to use the criminal justice system and the incarceration as a deterrent to young people picking up guns and shooting each other. And to me, the analogy in my mind is like incarcerating people for their eating habits when they get sick from obesity, incarcerating people for smoking when they have lung cancer. Can you reflect upon a bunch of law enforcement people in here, what can we do tomorrow, not like after a convening of a bunch of people, but tomorrow, with how we interact with both shooting victims, their families, and with defendants who have been accused of possessing or shooting handguns, that might give us better outcomes given what you see in your rooms? That's
right up your alley, because I think Temple leads us in this whole endeavor.
You know, I don't know. One of the challenges I have is that I hear people who are very progressive, who will want to attack the police officers. And one of the things I always point out is that it's a complicated relationship in Philly in particular because so many of our officers grew up in the neighborhoods that they patrol. And in Philly, we're one of the handful of cities that allows its officers to transport gun victims. And I can't tell you how often I have victims who will say, can you get the cop who brought me so that I can thank him personally? It's complicated. So I can only speak in the context of Philadelphia, but I think one of the things that I think we have to create are opportunities for law enforcement to step outside of that role, as you're apparently doing, to have these first points of contact not be in the wake of a shooting, but in more community involvement. One of the challenges that we face in the hospital is the fact that when I talk to gun victims about how do we get you hooked up with a job, they say, well, why don't you get me hooked up here? And then I go to the HR folks and they say, well, we can't actually hire that individual because that individual has a prior record. We've got to work collaboratively and think outside the box so that you can help connect these individuals to the resources that are going to prevent them from coming into our hospital and coming into your contact.
Real quick.
Two quick things. One, trauma-informed care trainings. Second, changing drug policy, because we need to recognize that we have been incarcerating people who have the disease of addiction.
Join me in thanking this terrific panel. Thank you.